Welcome, everyone, to our transplant medicine seminar. I'm Karin Hienberger. I'm the president of Lifebold and also the chief medical officer of Patient Care America. I am joined here today by Dr. Crew, who is an associate professor of internal medicine at Columbia University Hospital. Really happy to have you here today.
Nice to be with you again.
Tacrolimus and cyclosporin, both are CNIs or calcineurin inhibitors. So how does that prevent the body from rejecting the organ?
So when the body is actually rejecting the organ, there are a couple steps. One of the first steps is that what's called a dendritic cell or an antigen presenting cell is taking tissue from your organ and is processing it. And so it begins to express some pieces of those cells, specifically some forms of protein on its surface. And then the lymphocyte has to come along and decide it will bind to the antigen presenting cell, the dendritic cell, right where that protein is being displayed. And then it has to decide, am I to grow and attack this thing, or am I going to let it be? And our immune system is doing this 24 hours a day, all over our body, scanning us all the time, looking for cancers, looking for infections, things like that. And so it's always sort of continuously scanning transplants. And so in lymphocyte biology, this is what we call signal one. It's when the T cells, the T cell receptor, binds to the antigen presenting cell and then tries to decide what to do. So that signal, when it binds, downstream of that, inside the cell, goes through what's called the calcineurin pathway. And so if you block that, you can engage the receptor, but you're going to prevent the signal from getting to the nucleus to then tell the lymphocyte to grow. And then not only grow, the lymphocyte, when it's activated that way, will secrete some other things called cytokines, some additional proteins that attract more cells.
Of course, if that is done, not differentially just to the organ, but it could be other cells, as you mentioned, constantly using dendritic cells or APCs or antigen presenting cells, then those lymphocytes will also be disabled. And that could have an impact on infections, on our cancers. That may be a side effect or a long-term consequence of tacrolimus or cyclosporin treatment.
Absolutely. And so the inability to activate the lymphocyte to then attack the organ, also, it's like you say, it's not specific for the organ. It is generally specific for lymphocytes.
Or in a pretty blunt ways of blocking the activation of lymphocytes.
Correct. And since we're talking about this pathway, one other important part of that system in terms of recognizing something as foreign or recognizing something as self is a different pathway, which we call signal 2, which is called co-stimulation.
Tacrolimus essentially blocks the activation of the lymphocyte, while mycophenolate or myfortic or CellCept blocks essentially the generation of lymphocytes. So one drug reduces the volume and one drug reduces the activation. Is that correct? Bluntly?
That's a great analogy. Yes.
So the patient now has a lack of lymphocytes in volume and has a lack of ability to activate their lymphocytes.
Correct.
So when a foreign agent comes in, such as something that you want to attack, that patient has an inability to mobilize its warriors, and it has an inability to give the warriors swords, right?
Yep, very good. Perfect. And that's why we see a lot of activation of lymphocytes in particular are screening virus. And so we see a lot of reactivation of virus infections, difficulties fighting virus infections. We also see other pneumonias, bacterial infections, urinary infections as well. But the predominant effect seems to be an increased risk of certain virus infections.
Virus. Okay. So we've talked about those two, and those are the mainstream, but you also mentioned a third one being belatacept. Tell us about that.
Sure. So belatacept, it works on the second signal. So for particularly naive cells, cells that have not been stimulated previously, cells that have not participated in rejection previously, it takes a little bit more to get them excited. It takes a little bit more to get them activated to go on. And so those cells, in addition to having the T cell receptor engage the antigen presenting cell, you also need to have a second signal, what we call signal 2. And there are a couple of them that have been described. The one in transplant that we frequently use is related to CD80, CD86, and something called CD28. So we can block that pathway, and it's very effective. Once you have 90% saturation of that CD86, you can no longer really stimulate T cells, particularly naive T cells that need a little bit more help. And so we have an IV medication. So it's an intravenous medication that we give once a month, half-life somewhere between 8 and 10 days. And so giving it once a month is enough so that at the 4-week interval, you still have enough immunosuppression around. You get your next dose. And it is very effective at blocking lymphocytes, and it's pretty good at reducing rejection. It's not quite as potent as tacrolimus and cyclosporin, but if you use it with thymoglobulin induction, one of the more potent induction agents, we see rejection rates around 15%. The big benefit is that, and we'll get into the toxicities of some of the CNIs later, is that it's much gentler on the kidney overall. And so many patients like it because it's only a once a month infusion. Many people are coming to get their labs done and coming to the clinic once a month anyways to see their physicians. And so getting something once a month and reducing the number of pills you're taking is a big help. It reduces some of the other toxicities and side effects of the CNIs, makes kidneys last longer. Some people think, like, particularly young patients who are working, they're not huge fans of coming to the clinic every month. And so occasionally it doesn't quite fit into their quality of life because they want to run away to Europe for 6 weeks and can't do it. You got to be back before that 4-week dose is due. And so we're trying to come up with other medications, improved dosing regimens. For example, this medicine happens to be an intravenous infusion, but you could imagine there are many rheumatoid arthritis drugs that are just injections once a week or every 2 weeks. And formulations like that might become a little bit more user friendly.
Yeah, so does belatacept need a combination with mycophenolate?
Correct. So it needs one other drug with it, most commonly mycophenolate, and trying to give it alone. We've tried to hold mycophenolate in the setting of some infections or low white counts and things, and we do see slightly higher rejections if you try to use it by itself. And I should say all these medicines, it's difficult to use them by themselves. The one that people have occasionally gotten away with, like tacrolimus, without mycophenolate or prednisone. University of Pittsburgh for a while was kind of investigating how low you could go with medications, how far you could space things out. And they had a protocol for a while where after 6 months in low risk patients, people had not had rejection, had good kidney function, had not developed any antibodies against the kidney. They had a trial where they were reducing mycophenolate and stopping it completely and just keeping people on Prograf. And about 17-20% of them actually developed rejection. Now, that meant that 80% of people didn't have rejection, and those 80% were spared some of the long-term side effects of mycophenolate. And trying to establish that balance, kind of going back to your original question earlier, like how do you know how much to give people? If we could have predicted a priority, who was going to reject or not, then you could easily decide, okay, this person needs this much mycophenolate, this person doesn't. The lymphocyte test, there are a couple other tests looking at new ways of HLA typing people, new ways of matching the proteins that may help us figure out which ones are more immunostimulatory or not.
So let's talk a little bit about the side effects. We talked about mycophenolate and how it affects the intestinal lining and cause GI effects, and also perhaps anemia and low white cells because it affects the DNA. Let's talk about tacrolimus, because we mentioned it a lot, but we haven't dug into the details of the side effects.
The calcineurin inhibitors and tacrolimus, one is just general immunosuppression and infection, which we kind of hit on with lymphocyte suppression. In terms of drug-specific problems, things that we worry about with tacrolimus are actually they make the creatinine go up, right? And so here we're giving an immunosuppressant to help protect the kidney transplant, and unfortunately, it causes graft dysfunction. So it's tacrolimus early after the transplant. It causes the blood vessels to constrict. If the blood vessels are constricted, not as much blood flow gets to the glomeruli, that gets filtered, and so people's creatinine goes up. We also see when we do a kidney biopsy, we see some other forms of toxicity where it can affect the actual function of the tubular cells. They're not processing proteins correctly. Over the short period, that's actually relatively reversible. You can lower the dose. Well, there's only so far that you can lower the dose, though, before you start seeing more rejection episodes. And so there's some people whose kidneys are so sensitive to it that we like to switch to an alternative medication. Like now, these days, belatacept would be the most common thing to switch to. Some people have a very severe reaction. This is not nearly as common, but that damage to the kidney, instead of just being a little bit of the blood vessel squeezing down, they can actually begin to form blood clots inside of the kidney at the microscopic level, something called thrombotic microangiopathy. Now that is, actually an emergency where we would either stop the medication right away. Some people need plasmapheresis, some people need additional steroids, but that's something that is actually an acute, more severe form of the sort of endothelial blood vessel kind of toxicity. There are other sort of, I don't want to call them inconveniences because for the patients that's actually very severe, but maybe not as threatening to the kidney graft. Tacrolimus use is associated with a slightly higher rate of diabetes after the transplant, particularly when used together with steroids. So at 5 years after the transplant, if you're on tacrolimus and you take prednisone, about 20 of our patients will develop diabetes that they did not have before. We see some changes in nerve functioning. So occasionally there's what's called, if you go to our waiting room and ask people, everyone's talking about tacrofog or brain fog because the medications, again, not for everybody, but sometimes they can cause issues with memory, cognitive function. I have a patient who was an accountant, for example, and forgot how to add numbers because he just couldn't manipulate the data in his head.
Is that dose related for those people with the cognitive dysfunction?
Usually, everyone's sensitivity to it is a little bit different. So we have some people who only have those side effects when their levels are 2 or 3 times what we would think is therapeutic. There are some people who get 2 or 3 doses and all of a sudden they develop a kinetic mutism where they just stare out into space and can't process anything. Something that's severe is not common, but early after the transplant, it is common for people to complain of a little bit of brain fog, and that usually gets better over 3 months, 6 months as our target levels of the medication go down. And then sometimes we see some electrolyte problems, and so tacrolimus in particular is associated with having trouble with the kidney getting rid of enough potassium. And so many patients will have a potassium restricted diet initially. Some patients need an additional medication to get the potassium down to keep it within a safe range. That side effect happens to be a little bit more common in patients who have diabetes because diabetes can also affect some other hormones called aldosterone. So there's some electrolyte problems that we see, a little bit of tremors and brain fog, a little bit of diabetes. Worry most about, and the reason that we're most concerned, that we worry at least specifically about the long-term impact on the graft function is really the sort of long-term nephrotoxicity, long-term kidney toxicity.
That's hard for the patient to measure besides coming into the lab and getting creatinine. That gets us to the adherence, the importance of, we don't like the word adherence, but for patients, it's a really important word, right? To not only take the drugs, but also to come in and do testing, because there is no at-home test for trough levels of tacrolimus or creatinine. I've often wondered why we don't have a trough tacrolimus test to do at home, because it seems like the tacrolimus levels do vary, and when they are higher, the side effects do increase, and we do have an additional risk for kidney damage. But it seems like no one has really developed that. So we need to go into a hospital or a lab and measure these things. The first year is special, but over time, a transplant patient, how often should they measure creatinine and tacrolimus trough levels and other values?
Sure. So, at the beginning, when we are trying to get the levels right, and I mentioned earlier that rejection happens most often at the beginning of the transplant, we do lab work twice a week, then it goes to once a week. Long term, after the first year, here we do blood work once a month to follow the tacrolimus level, to follow the creatinine numbers. If you get through the second year, rejection tends to be pretty rare as long as you keep taking the medication, in the order of 1 or 2% per year. And so we don't see our patients as often, and usually by that point they're on kind of a more stable dose of medication. So beyond the second year, here for our kidneys, we check the blood work every 3 months, and that blood work would include obviously the creatinine. Would check a level of the medication, a level of the potassium. It would check blood counts, make sure the white blood cell count is okay, platelet count's okay, as checking the other side effect of the medications. In terms of the issues with compliance, the impact of compliance depends a little bit on how far you are out after transplant. And so early after transplant, you miss a day or two, you could begin starting to have a robust immune response. When you're longer out, it's not quite as common, but definitely is associated with developing antibodies against the kidney. And developing antibodies against the kidney long term is one of the biggest threats to the kidney, because we don't actually have great medicine to control it. Once you've developed these antibodies, they keep attacking the kidney. The cells that make these antibodies are very difficult to immunosuppress. And so it's the number one cause of sort of late graft failure beyond the first year, is actually chronic antibody-mediated rejection.
When you speak to patients, when you have your patients in the office, and we are talking to patients here in a pretty sophisticated level, how do you incentivize them, or how do you make patients after a year or two to take their drugs? Some patients keep an alarm clock, and every 12 hours they take their medication. Some patients take it in the morning and the evening. It may not be 12 hours in between. So I have two questions. How do you continue to motivate patients? And then secondly, how important is it to keep that 12-hour interval between the doses?
I wish I had a system that worked 100%. One of my colleagues works with a lot of pediatric patients and they struggle with this all the time. My personal preference is that people use a pill tray and an alarm on their phone. And for two reasons. One is every 12 hours makes life a lot easier. Having the pill tray, when you open it, it could be difficult when you're opening 4 different medication bottles to remember if you took it, or you're busy, you're not thinking about it because you've done it for so long, you have breakfast, you go on to work, and then later on you're like, oh, did I take my medicine or not? If you don't have it in the pill tray in the morning, because you're taking them out of bottles, you'll actually never know. But if you get home and you're like, oh, God, I missed that. The other good thing I like about pill trays is you get an entire week's worth of trays. You actually have a sense of, gee, I missed 3 doses this week. That's really bad. And it can motivate people when they recognize how often they're missing their medications to improve compliance.
How important is the 12-hour? Can that affect anything? Or is it okay with 14 and 10, 16 and 8?
If you're more than 3, 4, 5 years out, probably not that important. Certainly early after the transplant, particularly when we're trying to find the right doses, having it every 12 hours makes a big difference because we're checking the levels of tacrolimus or cyclosporin in the bloodstream. And if it's 14 hours instead of being 12 hours, the levels are off. Or if it's only 8 hours instead of 12 hours, like having the blood work on time consistently at the beginning is very important. If you're 3 years out and you've never had a rejection, you have to leave for work by 7:30 and you can't take your next dose until 10, that's probably okay. But the closer you are to being on time, the better off you are. The fewer missed doses you have, the better off you are. That's been consistently shown.
We have come very far, right? From the 60s, 70s, we have kidneys that survive 10 years. Rejection, it's less than 10%, right? In the first year. But over time, we're still struggling to keep those kidneys. If we're talking about one kidney for life, you get a kidney and you can keep it for the lifetime of the recipient. We're not there yet, but we've come very far. The surgical process has improved dramatically. We have patients, as you mentioned, in the hospital 4 or 5 days after a kidney transplant. Tremendous, right? They can go back. The other thing you said was in the beginning, it's really critical, really critical. It's always critical to take your doses, but in the beginning, it's really critical to check in and make sure you measure. And then I think you also said that the drugs we're taking, they address different parts of the immune system to make sure that our cells are both decreased and deactivated. That can cause some side effects that are detrimental long-term. So there is innovation ongoing. There are potentially new opportunities in the future where that immune suppression becomes more of a modulation, and it allows the patient to go on and live their life more normally, so they don't have to be worried about these detrimental infections and oncology, issues or cancer issues that can happen. So the matching that is done prior to transplantation with either a living donor, then in the moment, of course, according to the UNOS list, with the deceased donor, does that take into account the immune profile, or is that more the tissue type?
Well, so the tissue typing is how we match people, and we keep adding new proteins. Each of us has a pair that we get from our mom and a pair that we get from our dad, and so we used to only check 3 pairs of proteins. Now we're up to around 12. And that match, particularly for deceased donors, how closely those proteins match, seem to make a pretty important difference in long-term outcomes and in rejection rates. With living donors, the difference at 5 years is very small. But with deceased donors, the difference at 5 years is around 8%. But it turns out it's not specifically like just having anything different. The question is like, how different is it? There's some proteins that are very, very similar, only a few amino acids different. There's some that are very, very different and are more likely to trigger a more robust immune response. In Europe, they've been using something called HLA Matchmaker and looking for 3-dimensional differences, like how the protein actually physically looks to the body might actually make a difference in terms of triggering rejection, amino acid sequences within them and those differences. And so they're kind of calculating what's called an eplet. An eplet would be like how different something looks. And if things have a lot of eplets that are different, maybe they need higher amounts of immunosuppression. There's one study that comes to mind where they looked at people who had below a certain threshold of eplets tended to get away with much lower levels of tacrolimus without developing donor-specific antibodies and without rejecting.
Can you see
Again,
has a low level of eplets, it must be that the individual versus the donor, right? Because if the donor also has eplets that match with those, it still means that they need higher dose of immune suppression.
Well, right. So it's a question of like yourself versus someone else's protein. And so these proteins that we're talking about are called A, B, C, and then DR, DP, DQ. So say I'm what's called a DR2 and you're a DR4, your DR4 might have 30, I'm making this number up. So, okay, it might have 30 points on it that are different, 30 different eplets. Whereas a DR2 and a DR6, maybe those are only 3 differences. And if it only has 3 differences, then you can get away with less medication, maybe. And that scenario is actually a little bit different. So the DR4 versus the DR6 is going to have different eplet mismatches compared to the DR2 and the DR6. And so all of a sudden it becomes very, very complicated when you get to the number of actual matches that are available out there, coming up with meaningful data, trying to do a clinical trial of what your eplet threshold is for different doses of
Especially
medications.
in cases where, the patient just needs to get the next available kidney because they are on dialysis and they just need to get out of that chair. It is a difficult, almost ethical question, right? But at the same time, the science needs to move forward because it would be much improved for everyone if we had more maybe eplet matching.
Yeah. And so, like you say, you have to get off dialysis because the mortality on dialysis is so high compared. Transplants make people live 3 times longer and provide a better quality of life. And so we have to find a way to get the research going and improve people's quality of life at the same time. And so
It's always the controversy. It would be interesting to look at the different segments of ESRD patients and
mhm.
see which category can we actually do this kind of studies because they may be preemptive, they may not be as far gone. That category may be more suitable for an eplet matching program or clinical trial versus those who are just, looking to survive and get out of the chair. So you talked about these 3 drugs, 3 kinds of drugs. You did mention CD28. I know that there are studies in CD28, and then there are others, I believe, in CD40 ligand. There may be some studies in anti-CD2. What do you think of that future of drug development?
So the CD40 ligand, CD40 ligand, and CD8086 pathway with CD28 are where most people seem to be going right now. This belatacept medication and this pathway, one thing we did not mention is CD80, CD86 can actually also bind something that turns cells off.
Hmm.
And so when it binds to CD28, the cell gets activated. If it binds to something called CTLA4, the cell gets turned off. And so what you really kind of might be like belatacept version 2 will be, instead of blocking everything by blocking CD80, CD86, you'll just block CD28. That means when a T cell is engaged, signal 2 will actually become active in turning the cell off and downregulating it. And so there's a clinical trial ongoing right now in France and at Emory that are investigating a sort of newer version of belatacept, or at least a newer way to block that pathway. The clinical trials in humans are just starting, but it seems to be very effective, at least in non-human primates. The CD40 ligand pathway is very similar. It's also very potent. Some of the initial drug trials that were done in the early 2000s, unfortunately, the original version that they had was also activating platelets. And if you activate too many platelets, you begin to get thromboses and things. And so they've modified the proteins. They seem to be safe in terms of the risk of thrombosis. We're starting a clinical trial here with it. It's actually going to be a phase 3 trial on blocking this pathway in transplant patients. And hopefully, it'll be similar, or maybe even better than belatacept. I had mentioned, belatacept has been great that it prevents a lot of the toxicities from the calcineurin inhibitors, but many people worry about rejection rates of 17, 20% when you can get rejection rates as low as 6 or 8%.
Anything that you can say that will give hope to our transplant patients when it comes to the
Sure.
drugs?
So, well, I would say right now, actually, the quality of life of transplant patients is actually very good. Despite these side effects, we have a lot of alternative options out there that patients can use to give them an adequate quality of life without too many side effects. But you're right, we haven't gotten to that just one kidney for life yet. And so the couple things that are going on right now that are very exciting. So you had mentioned CD2 antibody, and so we're part of a tolerance trial here that uses anti-CD2 along with some additional pretreatments, and we give a bone marrow transplant at the time of their transplant, at the time of the kidney transplant. Those bone marrow cells that come along with it, they actually quickly eliminate any donor reactive cells. And so patients are left with an immune system that is very hypo-responsive against the kidney, and we can wean immunosuppression after 6, 9 months, a year. And we've weaned one person completely off immunosuppression now with our new trial. or starting the weaning process on several more. Now it's still research. It's geared towards people who have what's called a one haplotype. So this would be like a parent donating to a kid donating to a parent, or you'd have a 50% chance of having this match with a blood relative. Other things that are going on at a lot of other centers, though, you mentioned immune modulation. There are cells that turn the immune system off, what are called regulatory cells. And so T cells have regulatory cells, B cells have regulatory cells. Turns out that they're regulatory dendritic cells that can downregulate immune responses. And so there are other places around the world where they're trying to take some cells from the recipient, stimulate them in a way that generates a lot of regulatory cells against the donor. You infuse that back into the recipient, and maybe you can get away with less medicine. Maybe not completely eliminate the medication, but at least if you could get rid of one medicine or cut the levels of the tacrolimus in half so that there's less toxicity on the kidney, things like that. And so there's definitely a lot of research going on about how to use no medications or how to use fewer medications, modifying the immune system so that if you're using fewer medications or the immune system's modified, you're going to have fewer cancers, you're going to have fewer infections, fewer hospitalizations. All those things will lead to better quality of life and hopefully make the kidneys themselves last longer.
I think that's incredibly hopeful, and I really believe that it's going to get better. But I have to admit, and I have to agree with you. I live with, I've had 3 transplants now, and one that I have my anniversary on Friday for my second kidney. So April 19th was the surgical date last year. Obviously, I am very grateful to you and the team, because I remember when you took care of me in the hospital after the surgery, and it's a totally different life. I mean, I'm doing what I want. I live a life that very, very much more freedom, and it makes me very happy. And definitely I want everyone to have that opportunity. So what you're doing at Columbia and at other university hospitals in this country is really incredible. And I think we're all very grateful to you. So, okay, bye now.